Hi, I'm Jason Connor, a director and statistical scientist for Barry Consultants, and today I'm going to give a little talk about driving with your eyes open. So this is a clinical trial we've all done. Imagine you move to a new city and start a new job. So for instance, I live in Orlando, and imagine I got a job at the University of Central Florida's new College of Medicine. So when I moved there, I went and I bought a house in College Park. Little did I know that the College of Medicine isn't in College Park. In fact, there's no colleges at all in College Park. So College Park here is shown by A, and the College of Medicine is shown by B. So now I have to decide how to get to work. So we're all statisticians, and we've all had this problem before, and we all know what we've done. And if you're not a statistician watching this video, you seek out a statistician. And you do the calculation and you figure, I want to save 5 minutes. If I can't save 5 minutes on average on how I get to work, then I just go the prettiest way, or in Orlando, the way without tolls. So I think about what my variability is, which is about 5 minutes per way. I think of my clinically meaningful difference, which is about a 5-minute savings in time. I put it into a sample size calculator, and I figure out that I need to go each of these 3 ways to work, either kind of south and then east, or over and down, west, east and then south, or I can kind of snake through some back roads, which even takes me through the airport. But I have to figure out which way to get to work. So when I put this in a power calculator, it tells me I need to go each way 22 times. So that's just about 13 weeks of travel here. So at the end of those 13 weeks, I never ever calculate what my average is while I do this, but at the end of 13 weeks, I do the math and then I choose which way to get to work. I'm sure everyone here who's ever started a new job in a new city, this is how they figure out how to get to work. But of course it's not right. Even though this is how we all do clinical trials, none of us actually make a key decision like how do we get to work every day this way. What do? We might ask around the office, hey, who lives in College Park? Who lives near College Park? And you go and ask them, how do you get to work? You might try a couple different things. You might think, the first way here seems faster. The second way, not so much, but maybe there's some morning you don't have any early meetings. It's not a busy day. And you just try the other way again. So you might be reminded, oh God, this is why I never go this way. Or you might think, oh, this was pretty quick now. The construction's done, and you try that way more. But the key is, we kind of go the most common way, the best way most often, but sometimes we try other ways. But that's not how we do clinical research, even though that's how we make most decisions in our life. So we're going to try to think about common sense ways of making decisions and incorporate that with clinical trial design. So the actual clinical trial I'm going to talk about here today is called ESET. So there was a project NIH and FDA funded called Adaptive, in which we designed 5 neurologic emergency medicine trials. The one particular one, ESET, looks at patients with status epilepticus. So patients who are seizing get one drug in the ambulance, and if that drug doesn't work and they're in status epilepticus, emergency medicine doctors need to know which subsequent drug to give in the emergency room in hopes that their seizing stops. So this is something with pretty high mortality. Sometimes 10 to 20% of patients won't come out of their seizures and die. So this is a very important clinical decision. So they usually get benzodiazepines in the ambulance, and there are 3 drugs. Only one of these are actually approved to stop seizure in this indication, but 2 other drugs are FDA approved for other indications and frequently used for patients who won't stop seizing. So we have fosphenytoin, levetiracetam, I'm going to say LVT here, and valproic acid, VPA. And we really want to decide which of these 3 drugs should we recommend emergency medicine physicians use for patients in status epilepticus. So this is a comparative effectiveness trial. This isn't to get one of these 3 drugs FDA approved. So we don't have a control group. This is really like a 3-horse race here. And we want to know, the 3 drugs start out equal, but we want to know which one is best. So first, one question is, well, what is a type 1 error? And I'd argue, and I won't get into that in this video, that the consequence of a type 1 error is less in comparative effectiveness research. It's one thing to say that a drug that doesn't work is better than a placebo and allow it onto the market. But if we have 2 drugs that are equally effective and already on the market, the consequence of saying one is better than the other matters, but isn't quite as consequential. So nevertheless, we're going to control type 1 error to our standard 5% here. What we really want to know is which one of these drugs is the best, and try to quantify the uncertainty in that estimate, and which drug is the worst, and maybe try to quantify how certain we are of that decision. So we're going to use a composite endpoint in this trial that combines efficacy with safety. So the idea, once we give the second drug, we want the patient to stop seizing quickly within 5 minutes. We want the patient not to start seizing again. So we're going to require no further intervention for the next 2 hours. And finally, we want there to be no significant adverse event. So these drugs basically slow processes in the body. So one frequent consequence of the drug is it can put a patient in bradycardia. So for instance, that is an adverse event. So the primary endpoint is we stop the seizure quickly, the seizure stays stopped, and we have no adverse event. And we've powered the study to identify a 15% difference in response rate. This is a Bayesian adaptive design, and we're going to enroll somewhere between 400 and 795 patients. We may have some readmitters that we're only going to allow their first entry, but because this is an emergency medicine trial with patients coming in quickly, we're not going to be able to identify they were in the trial before. So we're hoping to maximize here at about 720 patients. So we're going to enroll between 400 and 720 patients. I'm not going to get into it here, but we're going to stratify patients by age because we realize the mechanism here may work slightly different in younger kids with status epilepticus versus adults. So this is a Bayesian adaptive design with multiple adaptive features. We want to adaptively allocate to favor better treatments. We want to drop poor performing arms, and this poor performing could mean relative to one another or relative to a 25% goal. And we're going to stop the trial early, even if we know the answer, or if we know we won't know the answer. If we know, even if we continue to expend all our resources, by the time the trial is over, we're not going to be able to identify either a best drug or a worst drug. First, I'll talk about adaptive allocation. We're going to randomize the first 300 patients equally, so we'll put 100 patients on each of these 3 drugs. Then, after the 300th patient is enrolled, we'll perform an interim analysis and update randomization probabilities. We'll do this based upon 2 factors. First, we want to favor the drugs that are performing better, and second, we want to favor drugs that perhaps have greater statistical uncertainty. And then we'll continually update randomization probabilities every 100 patients, which given the expected accrual rate of the trial is probably about every 6 months. If an allocation probability ever drops below 5%, we'll just round it to 0. We're not dropping the arm, we're just suspending it for the next 100 patients. And finally, if ever the probability the drug success rate is greater than 25%, is less than 5%, we're going to terminally drop the arm and only randomize to the other 2 drugs for the remainder of the trial. Next, I'll talk about early stopping. So we start adaptively randomizing after 300 patients. We don't allow early trial stopping until we have 400 patients into the trial, and then every 100 patients thereafter. So if ever one arm has a 97.5% probability of having the highest success rate, the trial would stop for success. For futility stopping, we do something different. We calculate the predictive probability that we're ever going to identify a best drug or a worst drug. And if that probability is ever less than 5%, we'll stop the trial for futility. Basically what that's asking is, given how many resources we have maximum left to spend, about the 795 patients, if even using all those patients is never going to identify a best or worst drug for status epilepticus, we'll just stop the trial, save NIH's money. The last way we could potentially stop the trials, if all the doses demonstrate they have less than a 25% success rate, we would stop the trial because then we probably need to explore other drugs altogether. Imagine we've enrolled 300 patients, 100 patients on each of the 3 arms. So at this first interim analysis, we see a 51% success rate on fosphenytoin, 55% success rate on LVT, and 64% on VPA. So it looks like valproic acid is doing better. We see here the probability each of these 3 arms is the maximally effective treatment. There's an 88% chance VPA is the best drug here, but this is only based on about 300 patients worth of data. We update the randomization probabilities, and those randomization probabilities are 12% to fosphenytoin, 22% to LVT, and 66% to valproic acid for the next 100 patients. The probability we're going to identify either a best drug or a worst drug by the end of this trial is 71%. So it seems like it's going pretty well. We just don't know the answer yet. So we enroll the next 100 patients. We've said we'd enroll 12, 22, and 66%. Randomization is never perfect. So we've in fact enrolled 11 patients to fosphenytoin. 6 of those were successes, 26 to LVT, 19 were successes, and 63 to valproic acid, 39 were successes. When we update those, we see our rates are now 64% for valproic acid, 59% for LVT, and 51% for fosphenytoin. Now there's an 83% chance valproic acid is the best drug here, just 16% for LVT and 1% for fosphenytoin. Because the top 2 drugs here are a little bit closer together, there's only a 50% chance that we're going to identify either a best drug or a worst drug by the end of this trial. But we update randomization probabilities and keep going. Notice here that the probability you get allocated to the best drug in the next wave is 57%. So what started out as equal randomization, you now have greater than a 50% chance to get enrolled to what appears to be the best drug in this clinical trial. So we enroll another 100 patients, and we can see how they do here on the slide. Now with 500 patients, we have a 65% success rate on valproic acid, 57% on LVT, and just 50% on fosphenytoin. The probability each of these 3 drugs are the best are 94, 6%, and almost 0 for fosphenytoin. So that's still not quite the 97.5% we need to stop the trial. For success, we update randomization probabilities, and you have a 69% chance of getting randomized to the best drug for the next wave. So we don't know yet, but as we continue to accrue information, instead of randomizing equally, we're going to focus patients on the drug that's doing the best. Finally, we enroll the next 100 patients. So we have 600 patients in the trial, and at this wave, we see 80% of the last group of patients we enrolled on valproic acid were responders versus just 61% on levetiracetam. So the result here is now that there's a 99.2% chance valproic acid is the best drug and less than 1% chance that either LVT or fosphenytoin is the best drug. This meets the predetermined success bound to stop, and the trial stops early because we've identified the best treatment. And this might be how we present our data in our New England Journal piece. See here, so each of these top three curves are the posterior distributions for each of these three drugs. And it's interesting that the best drug, VPA here shown in blue, has the smallest standard error. Our precision is most for the best drug, and that's really what we care about. We've expended resources in such a way not only that we've treated patients better, putting more patients on the best drug, but we also have a more precise estimate of the drug we're going to recommend emergency medicine docs use from now on. So that was one trial though, but one question is, well, on average, how is this trial design going to work? So the two outlined cases here, the case when all three of these treatments are equal. In the top, it's when all three treatments have a 50% success rate. In the bottom highlighted line, it's when all three treatments have a 25% success rate. So for instance, on average, when all three treatments only work half the time, but the key is they work equally well, we have a mean sample size of 507 patients, and there's a 1.3% chance we identify a best drug. But remember, there's no best drug here. So this is a type 1 error versus a typical fixed randomization design. So we still allow early stopping, but at fixed randomization, we have a slightly smaller sample size, but type 1 error is a little higher. The reason's interesting. When a drug starts to do better with adaptive randomization, we put more patients on it. So if that's just a random high, we actually test and we get regression in the mean faster. So that's one reason why type 1 errors are lower here. The next case we'll look at is when one drug is better than the other two. So imagine now one of the drugs has a 65% success rate. Both the other drugs only work half the time. In this case, the probability our statistical design identifies a best drug is 89%. The mean number of patients we use in this design process is 483, and we randomize 48% of patients to the best drug. If we compare this to a case where we have fixed randomization, we only have 87% power. The mean sample size is 497, and of course we're putting only 1/3 of the patients on that best drug. So this is a fascinating case. With adaptive randomization, we put more patients on the best treatment, we have a lower mean sample size, and we have a higher power. So in this case, we actually lose power compared to the fixed design. So here, the adaptive randomization case, we have 67% power to identify the worst drug versus a 79% case when we have fixed randomization. The reason, of course, here is because we're putting more patients on the two best drugs, which is good for patients in the trial, but we're putting fewer patients on the one dose that's actually different. So we have lower power to identify a best dose. And in the last case that I'll talk about here, we have one drug that only works half the time, one drug that works 57.5% of the time, and finally the best drug works 65% of the time. So this may be, perhaps a more typical case. In this case, the effect size between the best and the next best is smaller. It's only 7.5%. So powers are lower. Powers 50% with adaptive randomization versus only 44% with fixed randomization. But this is another case where we have higher power, a lower number of patients we need to use in our clinical trial, and a higher probability patients within the trial are randomized to the best treatment. So in summary here, comparative effectiveness is a great situation for Bayesian adaptive trials. We should do interim analyses early and often. Actually doing interim analysis only every 100 patients, which is about every 6 months, is pretty rare for us here. But in the status epilepticus case in an emergency room, we're actually going to go in and reorder IV bags that are sitting in a closet. We didn't want to do that too often, but you can update randomization every day, every week, every month, frequently more often than we're doing in this trial. But the key is the adaptive randomization here steers patients to better therapies and patients away from poor performing therapies, even though we, of course, don't know which treatment's going to be the best and the worst before we start the trial. And we're going to stop the trial as soon as we've identified a best treatment so we can publish these results and inform emergency medicine docs who are treating these patients. And much like the way we decide to get to work when we buy a new house and start a new job, it's really a way more natural way of learning and making decisions. Thanks for watching our video.